so that when they dial from one hospital to the other and they've got a file sitting in one directory, it pulls that directory, it sends the file, whether it's an Excel file, a Word doc, from hospital to hospital, back and forth, and then it sends an email to an administrator that says, there's a file sitting here waiting. So we had to go old school on some of these things. We're looking at situations where we can solve problems not just with new technology. One of the big issues is that at the last Arab Congress that they had in Dubai, it was last month, they're talking about big data. I don't know if you've seen, there's books written about big data. There's books and journal articles. But the one thing they're talking about is it's big data, small application. The applications are lean and agile so that they can be altered. The configuration management tools built into small, agile applications will allow you to do this, no matter what technology you have on this side. So, the Saudi CDC, the reason I was brought here, actually is talking about both healthcare and public health. Both sides of it. From the healthcare side, we have the Saudi National Healthcare Safety Network. We're talking about patient and staff safety. Both sides of the equation within a hospital. And we want to get better information so that we can protect the sick, protect the employee. On the other side, we're talking about public health, which is HESN, and this is about patient safety all over the kingdom. And we want better information there as well so that we can protect the well. I mean, this is about alerting. This is about trends. This is about understanding what's going on with disease. The Saudi CDC is right here in the middle. What it is, what it's supposed to be, is a national healthcare lab and the ability to validate through lab confirmation anything that goes on in Saudi NHSN or HESN. These two will eventually become one system. Right now they're two separate systems until we can start to bring them together. But the idea is that the Saudi NHSN and HESN will provide data to the Saudi CDC. We will have an emergency operations center. We'll have a business intelligence committee. They will actually, their job will be to analyze trends. Their job will be to sit and look at alerts. They'll probably even have a copy or two televisions, one on CNN and one on Al Jazeera to watch. Because honestly, the 10 years that I worked on BioSense, it never alerted one thing before CNN did. So we actually had a staff at the CDC watching CNN constantly. So, the Saudi Center for Disease Control and National Lab. Communicable diseases, we want to be able to test and validate. That's the whole idea of the Saudi CDC. So we included TB, HIV, STIs, malaria, influenza, dengue fever, other dangerous past accidents, and healthcare-associated infections. They're all going to come together in one place. The Saudi CDC will be accessible to all hospitals, not only in the kingdom, but eventually all hospitals in the region. Zoonosis, bioterrorism agents, non-communicable disease, including the chronic diseases, and their injuries related to that, and environmental health. This will be a one-stop shop where HESN will be the key application that everything comes together on. You'll have one place that you can go. One of the issues, and I talked to the gentleman from GE, is that they're looking at national registries. We're looking at immunization, I believe, is one of those. So, if there's a national registry for immunizations as well as issues regarding allergic reactions and things like this to particular antibiotics. If you've got certain reactions, Wouldn't it be nice to have something in a registry that says that you'll go into anaphylactic shock and die if someone gives you penicillin? But you get knocked in the head and you're bleeding and they want to put an IV with penicillin into your arm. So it'd be great to have one place to go to see all of this. So again, briefly about Hessen, Healthcare Electronic Surveillance Network. We're talking about an integrated public health system. The unique characteristics of this is that it protects public health through prevention, detection, and management. It enables the collaboration through interoperability. This is going to be interoperable with lab systems. It's going to be interoperable with other systems that are out there that we, HIS systems that we can ideally utilize, the industry standard HL7. We've got SNOMED up here, but I think we're probably going in a different direction. I'm not sure if that standard's been established yet. But it includes 7 major components that are utilizable. We should have, I think we have by now, a kingdom-wide license for these 7 modules. So, communicable disease case management, outbreak management, immunization management. I'm going to go to materials, vaccine inventory management, notifications management, and work management. The family health is actually a module that can be used by clinics as their family health clinical module, and it integrates all together with one. We had talked briefly before about EHR. EHR, I'm not going to go too far with that, but I'm going to say it's a myth. The problem is that with everyone using their own homegrown systems or somebody else's systems, integrating these all together is problematic. If you were to buy Cerner today for the entire kingdom, by the time you start Cerner today and you do the last implementation, they won't talk to each other because of technology changes, because of standards, unless you spent a lot of money to ensure that upgrades are done across the board. But the idea for us, for Hessen, is that we connect to the Ministry of the Interior's Al-Elm database. And this becomes our EHR. Because in the Al-Elm database, there's only one instance of your national ID, of the ICAMA number, visa number. If you come in from somewhere else in the region, the number that comes with you. There's only one. Only problem we had to deal with is people who are illegal and how we actually collect that information. But statistically, it's not significant unless there's a lot of illegals who happen to get one kind of disease. So, talk about Saudi National Healthcare Safety Network. This is based on CDC's model, the model that CDC put together 25 years ago and has changed. Definitions have changed. SIR has just recently been the major change. And what we've done is we've put together this application so that it's open source, it's free, it's scalable. It can be used in a clinic, a hospital, or a sector, or a region, or an entire country. That's how scalable these applications are. They can be used, Hessen can be used because you are just a single unit. You could be just the clinic, and Hessen would be used only by you there. You'd be just a hospital, it's the same thing. Well, the Saudi National Healthcare Safety Network, it's the same way. The data can be entered locally and stored nationally. The data can be entered locally and stored locally and updated periodically. These applications are small and very configurable. So the Saudi National Healthcare Safety Network, SNHSN, provides a tool for healthcare facilities to collect information. You know, I quote about 6 different places, and some places say healthcare associated infections, some say hospital acquired infections. I'm going to go with hospital-acquired infections because that's the one I see the most. But when I pull data from other places, I should really look at it and read it. But the idea is that the HAIs, they need to be standardized. The definitions have to be the same for everyone. The kind of thing that happens in each hospital has to follow the same rules, has to use the same flow diagram, the same determination, the same symptoms. If not, then again, we're not comparing the same thing. So many hospitals are reporting this information without regard to definition. So we are dealing with form-based. So even with Hessen, with Saudi NHSN, with other applications, the osteoporosis one we have, the TB one we have, it's all form-based. And the forms, I'm going to show you one example of one, and we're not going to go too much farther with that. But we can take this analysis and compare it to national as well as international rates. And of course, we want to have an outcome and process measure that shows performance improvement. This is really critical for JCI accreditation within the hospital. So if we can provide the data collection on an international level, this is going to take some time, I think. But at the international level, we can get a valid estimate of the impact of these adverse events, these infections. So this is a form. If any of you have worked in infection control, and you see this form, you open up your GCC manual, it looks just like this. It's no different. The difference is that we've automated the functions of the form. So when you put this information on a website, if you put it as a PDF read by Adobe Reader on your iPhone, on your iPad, on any device that can read Adobe Reader, then you can enter this information, and it's validated. The data is validated, so you have to enter a patient ID. You have to enter a gender. You have to enter a date of birth. You have to enter location. Facility IDs, that's really up to you. At the Ministry of Health, we have a random number generator that has numbered all of the facilities. So what they end up doing is every facility ID can remain anonymous because they are the only ones who know their own facility ID. So we can share information between hospitals. We can share information between sectors or regions because they don't know who the other hospital is. We try to take like hospitals so that they can actually benchmark against each other. And if it turns out that there's one hospital doing something very well, we end up taking that hospital, getting their permission, and they share information on what they did and what their policies are and if their procedures are different. We also have the ability to do training. We have a training program that pulls SMEs from all over the world to go to infection control departments, to go to NICUs and PICUs, to go to ICUs, to go to operating room theaters, and to provide input as well as validity to some of this information. So one of the things that you'll see here is that we have the ability to diagnose, and that's very hard to read, the ability to diagnose, and once you click on this information, he took my pointer, this information just below event information, this happens to be a county. If there's a UTI diagnosis and you click yes, it will take you to a flow diagram, and you have to answer the questions properly. So you don't have to worry anymore about the definition. These are the symptoms. If you click the right buttons based on lab information that you've received back, then what it does is it will bring you back with the correct, thank you, with the direct diagnosis. So that's this one here. And then you can see for UTI, you've got criterion 1A, 2A, 3, and 4. I'm not here to teach you medicine, more medical informatics. So the idea over here is that we've got gram-positive and gram-negative results from a lab, date of record, and you've got the antimicrobial sensitivity. We've got the fungi sensitivity. Well, this has all been automated. You have to select something from this if you have a lab report back. One of the questions that we're asked many times is, we've got a number of medications or different types of antibiotics listed, and you tell me, we have one that we get a test result back that's not on the list. We have actually vetted this list across the kingdom, and if you buy a lab test from a particular company, I don't know if GE sells lab tests or not, but if you buy a lab test and it gives you 45 results every time you submit something, there's a good chance that the results that they send you back don't have a comparative medication or implementation here in the kingdom. We don't buy it. So everything that we have is on these forms. And again, the Saudi National Healthcare Safety Network, I can give you a stick and you can take it home and use it. It's that simple, if you understand infection control. So, summary. What I've attempted to do in my 3 years here is to alert different individuals to requirements, to infrastructure issues, to policy. There are numerous areas that we can always improve. I think part of what goes on, at least at this level, is the understanding from a managerial aspect to the fact that they have probably very little control at the bottom layer. They can dictate change, they can dictate policy, they can dictate whatever they want to implement. And by the time operationally you get out to the field, you find out nobody's even heard about what's supposed to go on. So we have communications issues, we have change control issues. But what we need to do is we need to understand our system's healthcare. We need to understand how the information works and what the workflow is, and if it's consistent. We have 264 hospital systems. Do they all use the exact same workflow? I hope so. They started out with the same workflow. What they've ended up with is what has been necessary to do their job. They may not have the organizational staffing to fit that model. They may have had to change things. Over time, you do what you have to do to the benefit of your patient. That's the critical piece of this. So we want systematically to determine a plan of coverage based on geography and organizational stratification. The key here is to understand diseases, where they occur. One of the principal problems I have with the epidemiologists at the Ministry of Health, some of them don't understand what a denominator is. Some of them don't understand what threshold analysis is. The example I gave you before, 5 cases of dengue in Jazan, 5 in Jeddah, 5 in Riyadh. If you were to just throw that up based on population, it would look like Riyadh barely has a problem. But if you have 5 cases, it could be an outbreak. So understanding and be able to do threshold analysis and to determine a plan of coverage is also critical to this. So if you've got personnel who are responsible for specific diseases or for specific types of infections in hospitals, then they need to understand. You need to understand, if you're assigned to this area, everything regarding that critical piece of your job. Now, I teach, I have to say that I'm probably very dangerous as an epidemiologist. But I teach epidemiology because there is no one else. There is no one who understands the requirements for it. I teach biostatistics. People want to know specific diseases What do I do to analyze my data? I received 1 year's worth of data from the city of Mecca, the 5 principal hospitals there. And they asked, I would like to have this information evaluated. And so I took the information to the person responsible for this and handed them the information. And they turned around and handed it back to me and said, can you do it? I don't understand what they want. So it's a critical piece of what we need to do to understand what the plan of coverage, what the geography is, where you're responsible to actually do an organizational strat. Now, to determine the component architecture framework to meet internet-based mobile and data needs. We've done that. Amna and her project team are very instrumental at moving forward and training and putting things together based on wins and losses. I mean, there are some areas where the infrastructure can't be retrofitted to our standard, so they have to adapt. You'll have to adapt. This is one of the other areas is to use lean project management based on agile methodology. This is for those of you who are IT analysts or IT based, this particular piece here is critical. If you are stuck attempting to fit your application to a structure, then you're basically stuck with that structure. Unless you can figure out a way to alter the two so that they fit somewhere in the middle. And then we want to be able to show incremental progress. This is part of the JCI accreditation. We need to understand benchmarks from year to year. We need to show improvement. I'm running up against certain CEOs in hospitals who keep their data very close because they're afraid of punitive measures. They're afraid that we're going to come in and want to take over something. When, in effect, you're better off going to the hospital, and this is what I did to the regions, this is what I did when we initially started out, was we told them that this is not to be punitive. What we want to do is we want to assess areas where you need training, and we will provide you with the training. We'll make the recommendations for training. And then we'll come back and we'll assess again later. That way we can actually work together to solve problems like this. So, to access and monitor health status of the community, of the hospital, of the kingdom. We want to detect, respond to, and control outbreaks and biohazards. This is all what surveillance is about. We want to guide public health policy, services, planning, and priorities. Priorities is the critical piece to this. When you've got an organizational structure, you need to be able to manage that structure. One of the things that we had talked about with Hessen, it turns out that there's too much of a distance between headquarters and regions. So they're starting to make, and have made in certain strides, they're starting to make regional coordinators for specific diseases, regional coordinators for infection control. That way the quality of the data, the quality of information that's brought forward is on the shoulders of the regional coordinator. We can work with them. We can train them. We can give them certification training in outbreak management. We can give them certification training in how we want the quality of the data to be realized. Then we can understand better how we need to follow up with particular regions. Again, evaluation of the control programs and interventions. We want to be able to do an assessment, and then we want to be able to reassess. Generating hypotheses for applied public health research. This is where we do the evidence-based research, evidence-based medicine, evidence-based nursing. Until we start to get to the mentality that our nurses probably do, and I'm not going to say they do more work than the doctors, but there's more of them. They're prevalent throughout all the hospitals. They see the problems. They see the issues. If there's some of them that can't be used to do evidence-based nursing, evidence-based practice, to bring that information to bear, to make recommendations, then we have an issue. We want to integrate with electronic medical records and laboratory information systems. We want everyone to be able to communicate. One of the critical issues in surveillance, we want to be able to generate a lab request from Hessen. We want Hessen to be able to request in certain places and go to the national lab and get the information back in Hessen and report it back to the local HIS system. This is happening. This will happen over time. And then it doesn't matter who you talk to, anywhere within the region. I've talked to people in the Emirates. I mean, they should really be a lot farther than they are. But they're looking to us. We're leading the way here. They're looking at our systems. They're looking at Hessen. They're looking at NHSN. They're looking at the overall strategy and structure. They're looking at our IT folks. They're looking at the people who come here and talk and inviting us to go other places. So this is what has happened based on the fact that we've actually started down this path. So, did I not do? Oh, wrong way. So I want to thank all of you. If you have any questions, I think now is the time for you. If you haven't woke up yet, then coffee downstairs.
Thank you, Mr. Gann, for the excellent elaborative lecture about the status of health informatics in Saudi Arabia. Now we will open the floor for questions, if anyone has a question.
This is Dr. Samir Al-Masri, Professor of Medical Informatics at KSU. I'm in the process now to move to international healthcare company. Thank you, Russell, for the presentation, and it's good to see your other side of your personality, because I know you were helping a lot training our kids in baseball.
Yes.
Thank you very much. And now it's good to see your professional side of your personality. You mentioned like just to comment or ask you a comment and a question about big data. I was actually one of the guest speaker at the Big Data Conference in Arab Health. And as you know, I'm here to promote big data. Big data becomes now revolution in the technology. And obviously, revolution in all industries, including healthcare. Everyone now talking about big data and the value can bring to businesses. Companies, they invest heavily in big data. As example, GE in 2013 invested $2 billion only in what they called industrial internet, and that's exactly what that mean big data. So, where are you as Ministry of Health of this big data strategy? Are you investing in big data, especially when you talk about surveillance? Big data, it's kind of a data-driven system and analytics, and it would be very important for surveillance. And you mentioned